Hello everyone, welcome back. Welcome to our live Q&A webinar. Our panel of experts will try and answer some of the many questions that people watching this weekend's convention have submitted. To introduce our panel of experts, firstly we have Professor Adrian Newland, Dr. Drew Provan, Dr. Sue Pavord, Dr. Nichola Cooper, Dr. Quentin Hill, Dr. John Grainger, our senior patient mentor, Mrs. Rhonda Anderson, Dr. Cynthia Neunert, and all the way from Sweden, Professor John Semple. Adrian, over to you, sir.
Thank you, Mervyn, and thanks the panel for giving up their afternoon and or in Cindy's case, her morning to come and talk to you all. We've got quite a few questions that have come through, but if anyone has any questions, they can put them on the chat function, and we'll be monitoring that and can pick them up. So we've had some very good talks over the last 2 days, which have covered lots of areas in ITP, and I think that's raised quite a lot of questions relating to treatment, the cause of ITP, and the problem the patient has. And we'll revisit some of those with some of the questions that have come through to expand some of the points that have been made. We did have a very good Q&A yesterday discussing COVID. I guess that'll come up a little bit today, but I'd like to concentrate a little bit more on general ITP rather than COVID, because it has rather dominated everything over the last few months, and indeed over the last year, but certainly with the vaccine over the last month, it's generated a lot of discussion, and there are 1 or 2 issues there that will come up. So keep your questions going. We've got about an hour. Hopefully we can cover a whole lot of those. And please make use of the panel we've got who have an array of talents. So we'll start off talking a little bit about treatments, and this came up a little bit earlier today and also yesterday and several times relating to steroids and the use of steroids. Certainly one of the areas of advice with treating patients in the COVID era is to reduce the amount of steroid that we're giving. And certainly the 2 guidelines, the ASH guidelines and the international consensus, both looked at restricting steroid usage. I think we're still going to be in an era of using steroids to start with because they're cheap and they're oral, and in general you don't have to admit patients if they don't need to come in. But I wonder, Nikki, you did the IWISH study. Would you like to kick off a little bit and just talk about steroids? And I'll bring in Rhonda at some stage to talk about the patient experience as well.
Sure. Thank you, Adrian. I think it's a really, really important question, actually. So for decades, centuries even, we've been using steroids for ITP. And I think it's one of the things that patients hate the most. And I think for people who've had chronic refractory ITP, actually many of them would rather have nothing at all and have bleeding than steroids. So I think we need to move away from steroids, absolutely. I think there's no evidence that they're curative. We still use them as first-line treatment. But I think there's a real need for more studies of upfront treatment. And I think, as Sue was saying yesterday, that there is a precedent now for using TPAs or other agents up front. And I do think that there's often the worst part of ITP is using steroids in patients. And I think clinicians need to understand that really well.
What do you think about the place of a DEXA scan in adults who are on long-term steroids?
Crucial, absolutely. And I think it's something that sometimes gets forgotten as well. So I think looking at both bone density and adrenal suppression as well, if people have been on steroids for long terms, I think that we need to better recognise the sort of adverse effects of steroids, definitely.
But moving on from adults really to the issue in children, I think I first became aware of the dreadful effects of steroids in looking at some of the children who'd been on steroids at much too high doses for much too long. And I wonder if maybe John or Cindy would like to comment on the issue now with children, because clearly it's a developmental problem in them as well as the sort of issues that we see in adults.
Yeah, so from the UK perspective, I think the message has got out to paediatricians who are treating ITP, and I think most people are now just moving to a max 7-day course and then quickly getting off. You know, I've too seen a lot of problems in the past, but I'm not really seeing that much now. Children hate the steroids just as much as the adults. Behavior goes very, very erratic. Sleep becomes a major problem. And we tend to, if we need in repeated courses of treatment, start to move away from steroids very quickly is what I would think is what we're seeing on the ground now.
What about early usage of the thrombopoietins in kids?
Obviously, the official licensing is still really from 6 months. During the COVID pandemic, obviously, we got permission to use for the over ones as well as for adults early on. My personal experience is only really from 3 months. I think Cindy can probably comment on, there's a lovely US study which Cindy's involved with using TPOs up front, so I'll let Cindy answer those bits.
Yeah, I think perhaps to get to your point, because we do much shorter courses of steroids up front in children than in adults, we kind of can see who's going to respond and not, and we're maybe a little more quick to move over to a second line agent as opposed to continue with long courses of steroids. So we are looking at this. There's a randomized trial right now through the Pediatric ITP Consortium of North America, looking at randomizing children to either a standard of care arm versus a thrombopag. In either children who are newly diagnosed, treatment naive, or in those who have received at least one other first-line therapy that they've failed. So anytime within the first 3 months of their diagnosis, they can get randomized on this trial. And the intent is really just to show, we're collecting a lot of patient-related outcomes data, because I really think that's where a lot of the benefit might be. It always comes down to as well a cost consideration. So we've built that in as well, just to look at that. But we do have an interest in this, and this stemmed from us looking retrospectively and realizing a lot of physicians are moving rather quickly away from repeated courses of steroids or IVIG and kind of preventing that platelet roller coaster of ups and downs to something a little bit more stable.
I think pediatricians are much more acutely aware of the issue of steroids in their patients. I think in adult docs and hematologists, I think maybe less so. Maybe a lot of them use steroids at high doses in malignancy, but I think we've had the point raised that quite a few patients with ITP, adults with ITP, will go on steroids at too high doses for too long, and if they don't respond, the doses are increased and they continue, and really they should be stopped. Obviously, it's something that I think the ITP Clinical Forum in the UK could potentially get to grips with. Do you see any reason, Quentin, of how we could get a grip on those sort of treatments outside what I would call the ITP community?
Yeah, thanks, Adrian. Yeah, I think it's a really important point as well, and there's evidence coming out now that lower doses have similar efficacy. There's the FLIGHT study looking at mycophenolate and steroid versus steroid, and the control arm had a relatively short and low dose steroid regimen, and the response rates were really comparable, certainly, to our traditional higher dose, the more prolonged doses. So I think that will be comforting to clinicians to see some upfront and fresh data that not using high prolonged steroids gives you a similar outcome. In terms of how the forum can help, I think that we need to have an educational role to clinicians. We were doing a session at the British Society of Hematology this year to clinicians on autoimmune complications. So it's opportunities to ensure best practice is sort of percolated through. So, that's one route. We have also done a good practice paper through the British Society of Hematology on osteoporosis prevention. And again, that hopefully focuses clinicians' minds on some of the adverse events. And we saw an audit this year at BSH, a poster where clinicians were actually auditing against that standard and, identifying potential improvements in terms of scanning, identifying those who benefit from bone protection while on steroids. So I think there's an educational role, and also just getting more people involved. So the forum is a group of interested clinicians. So I think hopefully we can all advocate and encourage people to sort of join and engage those discussions. So there's about 90 members now. So, I'd like to see more clinicians with an interest kind of coming on board and sort of joining the forum.
Thanks. It's interesting about the dose. I think Sue Pavord was mentioning a little bit earlier about with reviewing some of the treatments with COVID, where the amount of steroid given is much less, and yet the results are pretty similar to the higher doses. Sue, do you want to just expand on that?
Yeah, I mean, I think that's really good news, actually. We've done an audit over the last year of real life experience during the COVID pandemic, really to see how clinicians have been able to access the thrombopoietin receptor agonists and whether these were as effective upfront as the second line, which we're used to. And what we did show in the steroid group is that actually 20 milligrams daily had the same efficacy as 1 milligram per kilogram. And of course, this low dose is what we've been using in pregnant women for a long time, for many, many years now, because we're so worried about the side effects of steroids in pregnancy, like diabetes, that can really do a lot of harm to a pregnancy. And so we have become familiar with these low doses in pregnancy. And it's good to see that they are just as good in the non-pregnant context.
Yeah, I think that's a good point. I mean, we heard, for those of you who watched some of the convention earlier today, they had a great talk from a young ITP patient who illustrated really very starkly the problems of steroids. And we have Rhonda here, who's one of the ITP mentors for the association, but also a patient herself, and certainly was telling us earlier about some of the problems that she had with steroids. Do you want to just highlight that, Rhonda?
Oh yes, I mean, it was the lack of sleep. I was on a very high dose in hospital. The lack of sleep, I think, was sort of one of the worst things for me, about 50 minutes at night. The flushing and facial hair growth that I had when I was on the steroids for a long time, or not really a very long time, but long enough. Mood, feelings of mood, not very happy mood, and just generally feeling pretty awful, really. Quite hyper, I think. Probably quite hyper anyway. I didn't need any more. But also, I think the other thing that concerned me, and you have mentioned, is about the risks, the osteoporosis, and that really was not addressed. I had to ask for a preventative treatment for that, and they didn't know anything about it. So that was something else. And of course, there is the Royal Osteoporosis Society that people can contact as well. And, you know, I think it's very interesting that the lower doses are quite efficacious without, you know, having to go for the massive ones. But in the lounges, people were saying that they were on quite high doses in conjunction with other treatments, and they were on them for quite a long time. So, yeah, I mean, that's about all. Thank you.
Yeah, it is an educational issue, I think, trying to persuade people that what the new guidelines are saying, and that if you don't respond to steroids, you're not going to, so they should be stopped. Well, let's move on to second line treatments, and particularly we'll talk about the thrombopoietins. We had a very good talk from Adam Suker yesterday, who highlighted an issue that someone mentioned briefly here, which was the costs of it. He talked about the financial toxicity of thrombopoietins, which is clearly a case, obviously less so in the UK NHS economy, although I think we'll be pushed over the next few months about some of the spending on drugs, and hopefully that won't be squeezed. But I think using it earlier and using it more long term means the issues of treatment-free remission are important, but also there will be a number of patients who will be on it long term. John Semple had a question, was asked a question about the long-term effects of L-Trombopag, and I guess the long-term effects of Romiplastin are pretty much the same. Those were discussed, but I wonder if anyone has experience of patients who've been on these for long term and would like to make a comment on the long-term use of the TPOs. Nikki, do you want to kick off? Or Drew?
So I think for a large proportion of people, they can stay in very reasonably low doses long term, and I think we've had people probably for at least 10 years on TPOs without any adverse effects. In our experience, and of course that's just single centre experience, so we've had a couple of patients who have had bone marrow problems, but that's really early on in the treatment. So we haven't had problems with sort of long-term treatment with TPOs. They've been remarkably successful and incredibly well tolerated, actually, I think.
Yeah, I think, sorry, our experience at the London, as you know, Adrian, has been very good with the TPO receptor agonists, even long-term. And we know from the open label extension study and the long-term open label romiplostim study as well, that there's no new safety signals, even if they're used for 10 years or more. So these are safe drugs. And as Adam was saying yesterday, it's a bit like taking drugs for blood pressure. You wouldn't expect to be on for a few months and then come off your blood pressure medications. So that's a very good way, in fact, to explain it to patients who say, oh no, that's terrible, I may be on this for life. But I mean, we're on lots of things for life, and many of them will come off. But of course, even if you don't come off, it's not the end of the world, and they're very well tolerated.
Yeah, that's the treatment-free remission brings us a little bit round in a circuitous way to Tregs. There was a question about the etiology of ITP, and John spoke about this yesterday. I thought it was a fabulous talk. I really understood it all of a sudden with the soldiers going over the hill.
For the first time.
Yes. John, well, we had a question here about what makes Tregs go faulty. Is it environmental? Is it genetic? If it is environmental, what factors are there? Do you want to speculate on that?
Yeah, I mean, it's a very good question. I think one of the things that in the literature anyways is that they may be faulty because there's thymic defects, and that the thymus, where all these T cells get educated, it also educates the T regulatory cells. And if there's a defect there, perhaps because of an infection or some sort of an environmental factor, these Tregs can be released then they don't function properly. So we still don't know the etiology of them, of autoimmunity, and what causes it, but certainly the infectious hypothesis is probably the most common.
And do you have any comments on the treatment-free remission? There's a suggestion with our late colleague Roberto Stasi suggested that and showed that there was an impact on Treg levels in the bone marrow, didn't he? Do you think that's a genuine effect, or do you think that's just an epiphenomenon?
Yeah, it's since Roberto reported those studies, back in 2010, I believe. It seems now that any therapy that gets the platelet counts up affects the Tregs. Most of the patients before therapy, they have either low numbers or faulty Tregs, and it doesn't matter what the therapy is, as long as the platelet count goes up, the Tregs seem to normalize. And so the hypothesis that we're looking at in my lab is that maybe the platelets themselves have an immune role to play, and they're somehow regulating the Tregs.
Yeah. And there's also other questions here about genetic studies. If you have ITP, are you more likely to get another autoimmune disorder? Do these disorders run in families? Do you want to comment on that, or shall I now? I know Drew has also written on this in the past.
In general, patients that have autoimmune diseases, certainly ITP is a heterogeneous disorder, and the diagnosis is not a very good one. It's a diagnosis of exclusion, and 20 to 25% of those patients, you find out 6 months or a year down the road that they might have something else like SLE or something along those lines. And we know that autoimmunity with patients with different forms of autoimmunity, whether it be diabetes, or they usually have first-degree relatives or relatives that also have immune defects. So that suggests that there's a genetic component to autoimmune in general.
I think the data from the ITP registry also showed quite strong associations. I mean, the number of patients with thyroid disease, both under and active and over thyroid, and just even antibodies, but no thyroid dysfunction, were quite high. And you mentioned the issue of antiphospholipid antibodies. Drew, do you want to comment on that? Because you've done you've talked quite regularly, haven't you, about the association of environment genetics?
Yeah, I mean, it's a really interesting area, but it's a real minefield. I mean, John knows better than I. I mean, this is a polygenic sort of condition. It's not one gene that confers ITP and then another gene for autoimmune thyroid disease or celiac disease. This is probably hundreds of genes all interacting with variations in certain sequences, and when they act in concert, and then, as John was saying yesterday, you get immune dysfunction as well, and then you get your trigger, then you develop ITP. So sadly, it's a really, I mean, as you know, Adrian, we looked at and published our data on things like SNPs, which is not very rewarding for ITP at all. We thought it was at the time because it has worked in other diseases like juvenile rheumatoid and things like that, or celiac disease. I think our group at the London discovered 1 or 2 new genes that confer or celiac disease, but we thought we might find the same. And we did some sequencing, some exome sequencing. In fact, Nikki, you did some exome sequencing also looking for target genes, but ITP is not a thing. That's the problem, is it? ITP is not a disease. It's a collection of entities that we call a disease. And so until we can differentiate different types of ITP, it's going to be very hard to study the genetics. I'd be interested in Nikki's views on the exome sequencing or genetic approach to ITP.
Yeah, thanks, Drew. I mean, I think that someone I think really nicely has put it that ITP is a snowflake disease, that everyone's slightly different. I think family associations in ITP is not common at all. And I think that there are a number of different types of ITP. I suspect there are some that are going to be genetically caused, but actually pulling that apart is really difficult. And I think almost certainly that some patients have been diagnosed with ITP that actually have a megakaryocyte or platelet production problem. And for those reasons, actually doing genetics is really crucial to make the diagnosis properly. And I think where we are at the moment is we can do platelet panels. So you can do gene panel arrays to make sure someone doesn't have a platelet disorder. Much more relevant, Cindy, I can see you nodding your head, in pediatrics. It's really crucial, isn't it, not to over steroids or splenectomize someone that actually has a platelet production problem. But the immunology side is much harder to understand, and probably there are patients who've got regulatory T cell problems. Probably there are people who've got antibody or B cell related problems, and they both manifest as thrombocytopenia, but actually they have different genetic problems. So I think that's the issue around genetics. So we definitely should be exploring it more, but it isn't an easy process, and I think it'll be a slow process to get to a better understanding of it, I think. And we've done exome sequencing in about 100 patients now. We have identified some mutations. Is that you laughing at the dog?
Yeah, I was is it your dog?
It's not my dog, no. They're so annoying. They always bark at the end of a talk as well. But yeah, I think it's a really exciting era. We don't know enough about it yet, but it is going to be sort of transformational, I think, in the future.
I think when we started to set up the registry, I think it was Drew was discussing it with one of the other conditions that has a registry, and they said, well, you need at least 2,000 to 3,000 patients on your registry with DNA to start teasing it out. And I suspect that compared with celiac disease or whatever, ITP is a much more heterogeneous disease than that, and I suspect we'll need a lot more than that if we want to look at genetics.
So the other thing is really hard to describe a patient.
Yeah.
Actually, you know, the different types of patients. I think even the phenotyping is pretty hard in ITP.
Many years ago, I had identical twins with ITP, and one had a course of steroids and got better and never needed any other treatment, and the other one proceeded to splenectomy and then got better. And I lost touch with them about 20, 30 years ago, but it always amused me. But we've occasionally seen it in families, but it's extremely unusual, as you quite rightly said, and John highlighted as well. Okay, we could move on to other treatments. Actually, though, we've just had a question here which is very close to my own heart. It's all about alcohol. I just started on riflostin, and when I ask about alcohol, I'm no big drinker, but I like a couple of glasses of wine or G&T. How do I know? Should I steer clear of them? The answer to that is no. Of course, you can have a drink. It's one of these punitive things that doctors push on people and put them on drugs and say you can't drink. There are very few drugs which would be counteracted by alcohol, as long as you take it in moderation, like I do, of course. So we'll move on from that.
Yeah, antabuse isn't good.
Yes. Yeah. I'm one of the few people who can drink alcohol while taking metronidazole.
Oh, yeah, I've tried that as well. Where it's fine.
I don't have that gene. So
no, I don't
anyway, that's fine. So we heard from Adam yesterday, and a little bit from Vicky earlier today in talking about the splenectomy, but she was also explaining some of the work on switching of the TPOs. Do any of you have experience? So that we have a question here about someone who after some years lost their response to eltrombopag and then responded to riflostin. Do any of you have experience of that sort of switching? I know some of it in adults. I'm not sure about what's happened in kids. I'd be very interested to hear that. But Nikki, I know you were looking at that as well. But I think if either John or Cindy would like to comment on in the pediatric angle, I'd be very interested to hear that.
So we switch all the time, I think. Yeah. And I think it can be tolerability or response. So I think for either, and I think in kids at Cindy, John, sort of what your opinion is, but for some don't tolerate one or the other. So I think you can switch definitely from one to the other for either reason.
And is the old suggestion that if you swap for failure, the response isn't necessarily as good as if you swap for lack of tolerability or
yeah, I think probably.
Just small numbers, were those small number studies. So it's always worth, if you had one of them at maximum dose and it fails, or if it fails after a period of treatment, it's always worth going on to the other. I think that's a key selling point, isn't it?
Yeah, I think the same is true for children. When we looked at our retrospective study, we did have a handful of children that had been switched, and some responded to the second one. You know, we found sometimes with teenagers, Rimiplostim can be more observed therapy, where eltrombopag, you're requiring a lot of dietary thoughtfulness of a teenager taking a daily medicine. So the failure to eltrombopag was maybe more related to adherence and diet and all those other things. And then you switch them to Rimiplostim and they respond quite well. So whether or not it's a true failure, but I do think it's always, at least in my practice, it's always pretty routine to at least try them on whatever is available before considering them a TPO failure.
Yes, I think the first question to anyone on eltrombopag who loses treatment response is to go through dietary history, and and particularly after a long period, it's become slack.
Agree.
Yeah.
Agree. And it doesn't take much, it takes very little, amount of calcium. If you start to look up, one egg is enough to say you can't now take your medicine. So it's quite complicated for patients, really.
Okay, any other?
I was going to say the same thing about dietary history. I think it's just so crucial actually for eltrombopag that patients do get that right, and it's not straightforward. I've seen loss of response with Rimiplostim a few times, so good response and then followed complete loss of response, making me wonder whether there were neutralizing antibodies there, although I've not actually tested for them, but that sudden dramatic loss of response has suggested that might have been the case.
Yeah, sorry, I was just reading one of the Q's and A's. Getting on to alternate treatments, and obviously one tends to look at TPOs as the answer to everything, but obviously there's a certain group of patients who can't have them, those who've got potentially clotting problems. And when you look at the studies, a fair highish percentage actually come off the drug, not necessarily because of failure, they just stop. And I think something that Jim Bassell presented at EHA 2 or 3 years ago. Around 40% of patients actually end up coming off it for one reason or another. One of our choices here has been mycophenolate, which Quentin mentioned as part of the flight study as an early on, but we tend to use it later on for patients who we can't give thrombopotens to. I think, again, Nick, I don't want to keep pushing you into corner, Nikki, but you've got a lot of experience of mycophenolate. We've had a few questions here about the side effects of mycophenolate. What's your feeling about it?
I think that I think people feel more tired on MMF than they do on the TPOs. And I think I've stopped treatment more on MMF than the TPOs actually. But I think, again, as a short-term treatment to get people into remission, it's really good. And I think there are some people who do not respond to TPOs at all, or it's up and down, their platelets are really refractory, they require weekly blood tests, and those patients need immunosuppression. And I think MMF and rituximab are really good treatments for those people. So I think there's definitely a cohort of people who don't respond to TPOs, and actually TPOs make their lives really, really difficult. And it's been a very difficult year this year, thinking about immunosuppression with COVID, but we've used quite a lot of rituximab. I have a handful of people who only respond to rituximab and they end up on it every year and they've been fine on that. So I think the quality of life issue is crucial. So, working out what's the best treatment for somebody as to what they tolerate well and what's the right treatment for them. And it's not always a TPO. I think there are lots of other treatments and we just have to remember that, I think.
Can I just say something else about mycophenolate while we're on the mycophenolate? Because as well as being incredibly well tolerated and nice response rate, I think about 20% will have a treatment-free response once if you taper slowly, because we talk about treatment-free response as if this is so unique to the TPO receptor agonist, but it happens with other drugs also. And the secret again is have a period on the drug, let them get used to it, and then wean slowly. And our experience is I think at least 20% will come off and be on no therapy. So it's a nice drug.
Agree. Yeah, completely.
Well, many patients in the past responded in a similar way to intravenous immunoglobulin. When in the 80s, 90s, when there was a vogue for treating chronically with the IVIG, quite a few of those ended up with longer term responses, but of course that's not really available now. We did have a question about IVIG, whether it has any significant place in treatment now. I know it's hard to get hold of because of it's used like water in neurological disease. What are people's feelings about IVIG? When should we use it? How should we use it? Should we use it?
Well, I think the effect is quite short-lived, isn't it? So my personal use is when we need to urgently raise the platelet count. So for instance, if somebody comes in labour, and childbirth is imminent and the platelet count has unexpectedly dropped, then IVIG would work the fastest of all the treatments. So that would be the rare occasion where I would use IVIG. We're always a bit worried about the supply issues as well. We've had shortage of supply in the past.
Yeah. Quentin, are you involved with the immunoglobulin working party?
Well, both me and I think John was chairing the sort of group for ITP, and we were both there's a third edition kind of released, which gives some guidance on indications, and essentially, as previously ITP is a red indication. In other words, there will be, it is seen as a priority condition for access to IVIG in the UK. A little bit more detail was provided in this version regarding platelet thresholds for considering IVIG and dose as well. And I think that's quite important. We have seen the ASH guidelines specify don't give 2 grams per kilogram, 1 gram per kilogram is enough. And our registrars in the UK, HemeStar, undertook a large audit recently to see what practice was like and looked at outcomes, and that very much confirmed the fact that a 1 gram per kilogram dose is just as effective as 2. So for reasons of access and cost and efficacy, then I think there's some clarity now that we should be using 1 gram per kilogram in the first instance.
Yeah. Okay. What's the usage in the States like now, Cindy?
I think, we've tried to have a push in the pediatric realm anyway to really reserve IVIG for those children that have come in with presenting symptoms of bleeding, which you need to manage rather acutely, not just as the mainstay first line therapy, recognizing the side effect profile of IVIG, cost, the fact that it often then requires the admission to the hospital, all those other components. And then in the light of the shortage, there was an even bigger push as well. So yeah. Really reserved. Patients come to, there are patients that come that it's used as sort of maintenance therapy where they're getting infusions every couple weeks of IVIG, and they've been on that for a long time. And again, I think that just creates kind of a roller coaster that can drive parents a bit batty when they're then trending the platelet count until it gets below a certain number to give the next dose of IVIG. So we're really trying to move away from that kind of practice.
Yeah, so I think that's fairly standard now, isn't it? I think it's interesting to hear that. Just, moving on to splenectomy, actually, there's a question here that possibly John Semple should answer. Now, it's come from Rhonda. Now, I don't know if that's our Rhonda or a different Rhonda, but if it was Rhonda here, you can leap in. But when you had a splenectomy, your platelets are still coated with antibody. How does the splenectomy stop ITP, and how much risk of it coming back? And does it matter how long ago the splenectomy was?
So the splenectomy basically, what it does is that it removes the site of destruction, the primary site of destruction of these platelets. And if you fail splenectomy and you still have thrombocytopenia afterwards, there's other organs that can pick up and destroy platelets. The liver, even the gut has been shown to be a place where platelets can be destroyed. So if you fail splenectomy, there are other sites that can cause the destruction of platelets.
Yeah, Vicky McDonald presented earlier about splenectomy. She showed some of the figures through the registry and also showed some of the rather nice Indium scan pictures that showed where platelets were being taken up. I mean, I think the rate in the registry now over the last 4 years of splenectomy is about 3 or 4%, whereas in the 90s it was 35% for splenectomy. So it really has dropped off dramatically. And I think a lot of that actually has come from the patients themselves, that we always sold splenectomy as you have a 60% chance of responding. And of course, the patient then turned that back and said, but that means I've got a 40% chance of it failing. And so I think, although they're not universally accepted, if it's available, the Indium scanning is quite a good way of predicting. I know they don't use it in the States to any degree at all, but certainly in Europe and other countries, it's slowly being used. I think the results are pretty good in predicting. And I guess the reasons why, if there's antibodies still there, it's but your platelet count is normal, reflects the epitope specificity of the antibody. Yeah.
So the spleen is a secondary lymphoid organ, and certainly autoantibodies can be generated in the spleen. But once the autoimmunity is full blown, these T cells and B cells move elsewhere and get into the lymph nodes and that. So they're still making antibody, even though the spleen has been taken out. So you can still have antibody-coated platelets, but there's no place for them to be destroyed.
Yeah.
Yeah. I think the question there for patients who have no spleen, like myself, is since the platelets are still circulating with the antibody, how soon or how dangerous is it that you're going to have a relapse? And that's one part of the question. And the other part of the question would be, what are other consequences? I mean, I had my splenectomy in 2000, so it's a long time ago now. what are the consequences of living without a spleen, and especially as you're getting older? So what are the problems that you might have, or should you just not worry at all about it?
Are you asking me? I think the docs here, the other docs here should answer that, but certainly there's long-term effects of taking your spleen out. I mean, you need to have at least have antibiotics with you. Some people preach that, that's for sure, because you're prone to more infectious issues without the spleen. You need to be immunized, of course, and vaccinated for encapsulated bacteria, for example, before the spleen is removed. But there are potentially long-term detriments to not having a spleen, and it's mostly an infectious nature, as I understand it.
But in general, the spleen is what, a third of the total immune system, and the rest of the immune system takes over. I think the spleen
absolutely
is important as a sump. If you get, which is why you get the overwhelming infections. So which is the importance of the immunization. I mean, the UK, I think, is one of the few countries that recommends taking prophylactic penicillin or another antibiotic long term. It used to be 3 years, and I think many of us, for patients who've just had a splenectomy who are on no treatment and normal, is you probably don't need to, provided you are aware of the problems and have a supply of antibiotics close to hand should you get a temperature or whatever. So I think there are longer term issues of splenectomy, not necessarily ITP, but certainly the Framingham study in the US showed a slightly increased incidence of cardiovascular disease in long-term survivors for that. But I mean, the numbers were quite small from my recollection.
Doesn't the association still issue cards? What we used to, the UK ITP Sport Association, you know, I have no functioning spleen. That was the association years ago, wasn't it?
Yes, it was, Drew. Yeah, we still do that. Yeah.
Okay, because that's good for people to keep in their purse or their wallets if they end up being admitted somewhere, so that people know they have no spleen, so they don't sit on patients with fevers and rigors. Because the problem is they can be dead in a couple of hours if you've got no spleen. Unlike,
we also have wristbands as well with I have no functioning spleen.
Okay, good.
Okay, but I want to move on now. We had quite a few questions about fatigue. Cindy talked about this yesterday and really reviewed it extremely well, I thought, but highlighted the issues of fatigue, that it doesn't always respond to treatment. It's a multifactorial problem. Cindy, do you want to talk a little bit more about that, about the incidence of it and about response to treatment and what you can do to patients who are fatigued and how you sort of encourage them to get over that if you can?
Sure. I mean, it's a really complex, the issue of fatigue is so complex, and like everything else that we've talked about for ITP, likely very individual to each patient, right? What the main cause is, where it's coming from, and how we can address it. I think, as we've even heard, some of the treatments that we can use to treat ITP can make fatigue get worse even. So if that's one of our goals of treatment, then we have to readjust and make sure that, you know, we're not providing a treatment that actually increases the amount of fatigue a patient is having. I think some of the difficulty is that when we look at clinical trials and the data that we do have, we're lumping all patients together. So we may not see changes in fatigue for the individual patients. We also still have, you know, some of our measures may not tell us the whole story and the link between these things. So I think it's just important for us to keep collecting the information to then start to figure out what the more intricate story is. In terms of treatment of fatigue, the number one thing is really making sure that you're addressing anything that can be addressed. So if a patient has daytime sleepiness, for example, it's looking at sleep hygiene, things that might be unrelated to ITP, and making sure you're addressing those, addressing any comorbidities or co-medical conditions that might be leading to fatigue. We've talked about thyroid antibodies, thyroid disease, other things that can run with ITP that could be medically occurring and causing the fatigue. And then I think it comes down to doing whatever we can to support, again, increasing activities with patients, helping to encourage them to maintain their social structure. You know, when we talk to some patients, the fatigue and the lack of being able to interact socially is one of the more challenging parts of living with ITP. And so sitting down and having a conversation about what might make that better. Sometimes it's treatment. You know, sometimes we provide treatment for patients that seemingly the platelet count doesn't seem to be at a dangerous level, but ITP is really impacting their quality of life. There's some discussion in other chronic diseases about kind of incremental increase. So when you feel fatigued, trying to do even 5 minutes of some activity to sort of retrain the process that's occurring cognitively to stop feeling those connections and get back to a better energy level. I think this is something that every patient can discuss with their physician, what that might look like. It's very individual and very, very gradual. Not saying anybody with fatigue should go out and run a marathon, but just 5 minutes of activity gradually in increments might also be helpful.
I think the issue of exercise is an interesting one. Most people, when they think of exercise, think of pounding the streets or doing something like that. But actually, in another patient group I'm involved with, actually exercise can be little more than actually getting out of your chair or getting up and getting dressed and going for a walk. So I think I think the point you make is absolutely right. It's that sort of graded activity of that's equivalent with what you can do, not some mythical Superman running a marathon type of thing. So no, I think that's important. Quentin, do you want to make any comments on fatigue?
Yeah, I mean, I agree with everything that's been said. I think when I looked at the data on things like gradated exercise programs in other conditions, because there isn't a lot on this in ITP specifically, then it was broadly favorable. The only condition where building up exercise seemed to make things worse was chronic fatigue syndrome, which seems to be a condition apart. But for things like rheumatoid conditions, multiple sclerosis, etc., then there was published data that said actually people's fatigue levels could be improved by activity, essentially. And there's lots of ways of doing that. And that might be going out and gardening. It might be doing some of the things you enjoy that aren't necessarily kind of very aerobic exercises. But this concept of gradually building up some kind of physical exercise seems to be a consistent theme that it's beneficial. So I think that we can reasonably apply that to those with ITP but on an individual basis, you know.
Do you think there's been an increase in fatigue in patients over this last year because of the issues of COVID, the sort of stress, the maybe social isolation, those sort of things? Has that made it worse? Do those of you see a lot of patients recognize that, or do you think that's?
I definitely think there's a lot of anxiety, and that goes along with tiredness as well. So yeah. Absolutely.
I think the other thing with fatigue, it's also really important to rule out iron deficiency, because some patients with ITP, because of chronic low-grade blood loss or heavy periods or whatever, because of their ITP, may have become iron deficient. And iron deficiency is such a common problem amongst everybody. So, and it's treatable. So it's always worth, I think, that patients ask their GPs to exclude iron deficiency as a treatable cause of fatigue.
And I think Cindy made the point yesterday that, of course, long-term thrombopag can deplete your iron stores too. So it's certainly worth considering that.
I mean, the first step is not dismissing the fatigue, right? Yeah. To have a practitioner that's not dismissive of the fatigue, and then one that's willing to look for other causes, and then sit down and be thoughtful about what some, you know, a plan of care would be for that.
I mean, it's an interesting point that actually comes up on several occasions from some of the questions about the practitioner who's looking after them. Should they be going to an ITP centre? How do they know their clinician understands ITP? And there was one here that came after Drew's talk where they said thought it was fantastic. I thought it was really encouraging what was available, but this person's own clinician doesn't doesn't want to give them TPOs because they're worried about side effects. So I think there is this big issue of having clinicians that are sympathetic, but then all clinicians are different people. We discussed that a bit earlier with Quentin about what the clinical forum could do with the sort of major sense we have, but actually developing that sort of network link of trying to educate the people out there. And obviously the presentation you had at the British Society of Hematology this year, I think, is important for that. But it's a very long haul. I mean, Drew and I started to do this when I had hair, so it's these things do take a long time.
I think also it's something that primary care is probably very good at doing. People feeling tired all the time is a very common symptom, and I suspect there's things we could learn from our primary care colleagues. And I suspect a shared care sort of approach to this would yield dividends and probably throw up things that we may not have thought about.
Yeah.
So there's that side of it, and then I think we've got a way to go in terms of how we look for fatigue and how we assess what is and isn't abnormal, because we're all tired at times, and so what's pathological, and we won't know if we ask, and if we do ask, we have to ask the right questions. So I think that surveys, proactive questionnaires, things that can be presented pre-clinic, I think would be a great step forward in terms of sort of pulling that iceberg out and seeing what lies beneath in terms of the fatigue burden. I think we're missing it.
Yeah. In the last few minutes, maybe we'll move on to the topic of COVID. I think we can't avoid it for a complete hour of talking about ITP. And maybe there was a question here about whether we're seeing an increased instance of ITP following COVID and vaccinations. Obviously, Sue reviewed a lot of the UK data and discussed that yesterday. Sue, would you like to kick in on that?
Yeah, I mean, this the audit we did over the last year, so it was from the 1st of March 2020 to the 1st of March 2021. And so if we think about those dates, we didn't actually start the vaccine rollout until sort of January time. So the last 3 months of that vaccine, and yet of the patients with secondary ITP, the vast majority were vaccine related. So while we don't know the statistics of vaccine induced ITP compared to the background rates, it does suggest that it may be triggering ITP in some cases, or relapse.
Yeah, I mean,
ITP.
We just published in the American Journal of Hematology with Jim Vassell that in fact, they noted 22 patients that had thrombocytopenia post Pfizer and Moderna vaccination. One patient actually died of an intracranial hemorrhage, but there was already at that point 45 million doses given. So the frequency of these events is incredibly rare. And that's true for the clots with AstraZeneca and Johnson & Johnson. The same incidence for these clots is the exact same incidence for being struck by lightning. So the vaccines by far are safer than they have side effects.
I mean, a point we were discussing yesterday is that obviously in the UK, in the last 4 months, 50 million doses have been given, which is an enormous dose rate. So there are going to be side effects, and although the reason that there's less of an issue relating to other vaccines, and it's clear that probably MMR is related to thrombocytopenia that may be transient and mild, although occasionally it can be severe. That's been picked up, but in the others, it's because the vaccines are spread out. But if you give 50 million in one dollop, you're going to pick up side effects. But I think the point that there is some proximity to the immunization, it happens within 2 weeks of the immunization, tends to suggest there's a potentially causative link. Now, for patients who have ITP, who are coming up for vaccinations, what do you suggest to them about the level of platelet count pre-vaccination? What should we tell them?
Well, my advice is that they should have the vaccine when offered it, and be more vigilant in looking out for any bleeding or bruising manifestations afterwards. If they're particularly worried, or if they've had refractory disease or real fluctuations in their platelet count, then they could ask for a repeat platelet count at 1 week post-vaccine.
If they've had a reduction in the count post the first dose, what would you suggest about the second dose? Changing the vaccine, going on to Pfizer if they're to have the AstraZeneca, or
I would say it's very individualized. If they had a reduction after the first dose, I think it would depend whether they needed treatment for that, and whether it was resolved with a few days of low dose steroid, or whether it was really refractory disease. I think it's really important to have the second dose, and ideally the second dose of the same vaccine. But if there are concerns that the vaccine had triggered aggressive or refractory disease, then it will be prudent to actually change to a different vaccine for the second dose.
Well, one of the attendees at the meeting wrote on the site yesterday after our discussion, she'd had the AstraZeneca vaccine and her platelet dropped from 220 to 8 in 2 weeks. She was stabilized on Pred. She went on for her second vaccine and had the AstraZeneca one again. Her count then went from 300 to 510.
Adrian, it just shows you how little we know.
Precisely.
And I think that my practice has not changed that much. I think to reassure people, in the last 3 months, we have had some refractory and very difficult ITPs. I'm not convinced it's very different to this time last year. So I think it's a very individual. There are a few people who've got difficult disease. It's not my usual ITP patients either. So I think to reassure everyone on this call, I think it's a really uncommon event, and that we manage it as best that we can. And just like you said, actually having the vaccine is so important and so crucial. So.
And the survey that Mervyn was doing for the association with self-reporting, and obviously self-reporting is a whole other topic, but I think there were 10 patients who developed thrombocytopenia. Now, of course, those who didn't have bleeding problems didn't have a post count, but those who did have a post count, we saw it was 10 out of 206 who had a reduction in the count, and one of those went down to 6, but actually was 26 pre the vaccine. And in general, and I think looking at some of the other results in ITP, the dip is transient and comes back up again pretty quickly. It may need a dose of steroids, or it may need nothing. It may just swoop up if it doesn't go too low. But I think, as we've seen, the success of the program in the UK has been such that the risks of the vaccine are infinitesimal compared with the risks of the infection, unless, of course, you're now less than 40, when the risks of infection are significantly less, that on a risk and balance basis, probably you should go on to one of the to the Pfizer or the Moderna, which the other two are available here. But I think when you look at issues like slow COVID, which occurs in at least 25%, and 30% of those have had asymptomatic infection, I think it's really important to continue the vaccine. Cindy, do you want to make a comment?
I was just going to say, as a pediatrician, we've been dealing with ITP and vaccines for a really long time. And so if it gives anybody comfort to know, even in the pediatric realm where some vaccines have been associated with ITP, we've always continued to make the same recommendation, right? Which is that getting vaccinated is far better than actually coming down with the illness. And so maybe that can give some comfort to the adults that are listening, that we've always recommended vaccination in children with ITP, very safe practice, even to those that may have a link to ITP. So if we can learn from the little people, maybe that will give some of the bigger people comfort.
Okay. I've just got 2 more questions related to this. One is, should the older patient on an immune suppressive drug who's been vaccinated have their antibody levels checked? Do they have the spike antibodies to spike protein? Should we be doing that? Is that reliable? Or should we just assume that we know that the vast majority are going to be immunized, but a small percentage won't, and you have to accept that? I mean, I didn't realize it was freely available. I thought it was available as an experimental investigation, but I believe Nikki was saying yesterday that actually, if money talks, and you can pay and have it done.
I think that this will be something that will happen. I think that some of the data is coming out that certainly some of the patients with hematological malignancies and other cancers are not getting good immune responses. Yeah. So there is a big study called Octave, which is looking at immune responses in people on immunosuppression and other. I think we currently don't know whether just because you have an antibody to a spike protein, you are immune either. So it has to, there are people looking at exploring whether those are neutralizing and kill the virus. So I think we're not yet there, but I think we will be, I suspect.
Yes, and of course, even when the antibody level's gone, you still have your memory T cells around. But
yeah, absolutely. Still, there's a lot of people working in the area, so it will change every month, the advice on that, I think.
Okay, now my last question is there any connection between autoimmunity and VITT or cerebral thrombosis? Would you, because Sue, you've done looked into that.
Well, of the sort of 200 or so cases of VITT, so that's vaccine-induced low platelets with thrombosis, there does not appear to be increased risk from autoimmunity. So these risk factors we're looking out for all the time, and as yet we haven't seen that autoimmunity is particularly common in these conditions.
Okay, that's a very reassuring note to finish on. I don't know if anyone else would like to make any comments. I think we've had a really great hour's discussion. It's like sitting in a room having a chat with each other, and I think we've covered an enormous amount of area here, and I hope the patients and the listeners have had some reassurance from these discussions. I would like to remind them that, of course, this discussion will be available, as will be all the other talks on the association website. And if they have specific queries related to themselves, they can, or any queries, they can write in to the association to Mervyn, and he will share them out to the medical advisors who will gladly answer any points that we have. But otherwise, I'd really like to thank Mervyn for pulling the convention together. We've had some fabulous talks over the last 2 days, and many on this session here have given them, and we're really pleased for them to have given up their time, not only to pull the talks together in such an expert and approachable way for patients, but also to give up a lovely Sunday afternoon to chat as well. So I think we shall probably have a convention next year. It may be like this, it may be face-to-face. It would be nice, but of course we wouldn't have 520 people signed in from 30 different countries if we have it face-to-face in London. But even so, that's something that we will consider, maybe a hybrid of both. But I'd like to just once again thank you all, thank all the listeners, thank our sponsors who really allowed this to happen. Thank Jeff and his team who pulled the whole thing together, because I think this is actually a fabulous vehicle to have a virtual convention on, and I'm really impressed with the way it's worked. So I think on those notes, I'll hand back to Mervyn.
Thank you very much, Adrian. Okay, everybody, as Adrian said, that was the last session of this year's convention, although I must also point out the exhibit hall, the resource centre and the ITP lounges will remain open until 5:30. Please take this opportunity to visit our event partners on their booths in the exhibit hall. You can browse all the ITP Association materials in the resource centre and connect with lots of other ITPers in one of the lounges. In addition, as Adrian said, you will be able to dip back into the convention at any time over the coming months. All of the talks and presentations have been recorded. So if there's something you've missed, you can just log in and select the video you want to see and watch it again. Thank you for attending the UK ITP Convention 2021. Finally, thank you to everyone who made this convention possible. In particular, a huge thank you to all of our experts who've taken part in this weekend's event. Please keep a lookout on our website, itpsupport.org.uk, for updates on our plans for the rest of the year. We have some fantastic ideas being pulled together now for ITP Awareness Week in September, which will be published in the coming months. We're now looking forward to next year. If COVID allows, as Adrian said, hopefully we may be able to see you in person. If it is, it will be at the Royal College of Pathologists in London in May 2022. Thank you, goodbye, stay safe. Take care. Bye-bye.
Thank you, everybody. Thank you. Bye. Bye.